Hi, everyone. Welcome for the debate today. And our expert for the evening is Dr. Pooja Avasthi. She's a scientific advisor and consultant embryologist, Delhi NCR. And she's received IFS Achiever Award 2022, ISAR Embryology Excellence Award, and ISAR Youth Icon Award 2023. She has more than 10 years' experience in clinical embryology, author and co-author of many book chapters, research articles, and indexed journals, and she has special interest in embryo biopsy and cryobiology. I welcome you, Pooja.
Hi.
Thank you for being the expert in the debate and a very apt topic and very interesting topic of AI in embryology or embryo selection, and a very upcoming topic. And I think last 1 year, a lot of debate is already going on. So our first speaker will be Dr. Ishwarya. She's currently working as a consultant reproductive medicine in SGMC and GG Family Clinic, Trivandrum. And she's done her MBBS, MS Obs and Gynae, senior residency, and fellowship in reproductive medicine from Milan Fertility Center, Bangalore, 2022-2024, and has a lot of achievements and best poster presentations also. So, Dr. Ishwarya, the floor is yours. All the best.
Good evening, one and all. Now we are moving into the topic proper. The use of artificial intelligence in embryo selection. I'm a consultant reproductive medicine at a medical college, at a private medical college, Sri Gokulam Medical College in Trivandrum, in Kerala. Now, the definition of artificial intelligence in ART. AI involves machine-based cognitive functions like learning, reasoning, and problem solving applied to ART. It aims to optimize the IVF processes, starting from ovulation ovarian stimulation to embryo selection, going up to embryo ploidy determination and which embryo to transfer and when. Now, the topic of AI in medicine should not be going forward without the name Edward H. Shortlife. So he is the first person to write a program of AI in medicine. Now, various terminologies for AI. Now, basic introduction about AI is AI, machine learning, and deep learning. Now, in AI, that is a computational technique that enables machines to mimic the human intelligence. Machine learning, these are algorithms that help to predict, form predictions based on the data it is receiving. And deep learning is a complex situation in which neural networks with multiple layers are used to analyze a set of database. So one above the other, deep learning is the highest form of artificial intelligence that is available at present. Now, why AI is needed in ART? The objective mainly is to eliminate inter and intra-observer variability that is very common in human errors. Makes the process much more automated, increases the efficacy and the productivity. It can perform labor-intensive and tedious repetitive tasks. It is more accurate and precise. It avoids the human error as mentioned. It is more rapid. The time consumption for multitasking is much lesser, and it enables a process of standardization. And of course, there is no emotional factors or physical constraints as when with an embryologist. So how is AI put into picture? Now, in any process where AI is used, a flow of events has to occur. So we first have to define what we are aiming to look at, collect data accordingly, and store the data in various categories like patient data or images or videos, and then split and validate the data and build a specific model for interpretation of the outcome and test the model via multiple data implementation and implement the model in a clinical picture. Now, AI in reproductive medicine can be applied in various levels, as we already mentioned, at the level of ovarian stimulation, for semen analysis, for the determination of uterine factor as a factor of infertility, as well as embryo assessment. Now, this has already been mentioned. Now, AI in embryo selection, the topic proper. Now, in manually scoring of zygote, it is a very labor-intensive, subjective, and requires the presence of an embryologist in the lab at the correct time. The use of AI in pronuclear scoring can predict blastocyst formation and saves time for fertilization check. Algorithms can predict the developmental potential of cleavage stage embryos. Prolonged culture can be avoided, thereby reducing the chance of epigenetic changes. Now, AI tools which are available for blastocyst assessment, these require either static images or time-lapse images to be fed as the input source. It, however, not reach the accuracy level to replace a manual grading system completely. Doubts on the number and quality of images in the AI trained programs are still in a question. However, beneficial when multiple good quality blastocyst images are used and which can be chosen between. So there are two types of AI machines, embryo selection softwares that are available. One developed by Vitrolife from Sweden and Genia Biomedics from Australia, both of which have not been clinically validated yet. Now, AI, as we mentioned, can also be used for screening for aneuploidy. It can predict euploid embryos based on the display of normal human chromosomes. AI-trained models uses databases that include thousands of cells, mass-focused images obtained through a range of imaging systems, both through microscopy and systematic examination. It gives a predictive score like an embryo ranking intelligence classification algorithm or ERICA. It is an image-based pattern recognition software which helps to predict with a high accuracy, with high speed, the existence of euploidy and the likelihood of embryo implantation. Few and substantial work is still needed before its proper clinical use. However, it may be used to choose which embryo has to undergo a PGT testing. Now, coming to the AI proper in terms of studies, as I mentioned about the input. Input can be either a static image like an embryo picture at different levels, say day 2, day 3, or day 5 embryo, or it can be a dynamic image in terms of time-lapse imaging videos. Outcome can be at the level of fetal heart rate appearance or beta HCG or ploidy status or live birth rate. The best outcome predictor would be a live birth rate. The embryo population, as already mentioned, can be a day 5 blast or a day 3 embryo or even a day 6 blast can also be used in different softwares available. The metrics that we most commonly used are the accuracy, sensitivity, specificity, and most of the tests are validating human versus AI, which is better tested in an ideal scenario. Now, as we already mentioned, static images look something like this, which can be fed in the software along with the clinical data of the patient, which includes the age, BMI, previous attempt to stimulations to IVF, the stimulation protocol, and what the diagnosis of the patient is. Or a dynamic video can also be uploaded into the software. This is followed by intensive data processing, data splitting, and data balancing, which are highly coded and software developed. Now, the outcome, as we mentioned, can be at multiple levels at the time the fetal heart rate is diagnosed, or beta HCG is detected, or when a live birth is detected. Now, the problem with the diagnosis, the determining factor between a human based versus an AI is that all these studies are retrospective and there is a selection bias. What kind of embryos are finally transferred and which model is a better predictor, it is difficult to compare in these two models as well, though a few studies have made some amount of justice to the same. What does the evidence say? There is a good article in reproductive human reproduction in 2023 by M. Sully. Embryo selection through artificial intelligence versus an embryologist, a systematic review. Now, the key findings of this was AI outperformed the embryologist. Around 20 included studies showed that AI morphology prediction with a median of 75.5% in AI, whereas an embryologist of 64.5, a clinical pregnancy prediction of 77% in AI and a 64% in embryologist, a combined input image plus clinical accuracy was 81% in AI and 51% in embryologist. However, the best data was achieved in combining the embryo images and the clinical data when provided to the AI software. One more study, which was published in Nature Medicine in 2019, was based on the AI software IDAS. IDAS. It was a deep learning versus manual morphology based selection. To be fair, the IDA score compared the time between evaluation of an embryo by the software versus an embryologist. We can see that the time taken by an embryologist to an average is much larger than how an AI would score. However, it also found out the difference between the IDA score group and morphology group via the embryologist in terms of clinical pregnancy rate and live birth rate. This was a non-inferiority tire and it was found to be not significant. The time of evaluation time, however, was 21 seconds versus 108 seconds, the 10 times faster time efficiency in the AI group. One of the early papers in AI was by Tran, the deep learning as a predictive tool for fetal heart in pregnancy following time-lapse incubation and blastocyst transfer. They used the software called Ivy, which used raw time-lapse videos of the embryos without the manual annotations or the morphological scoring. So 8 IVF labs were identified across 4 countries, and a time frame of 4 years was allotted with an equipment of embryoscope, or the Vitrolife embryoscope was used. In this study, the overall testing database, the area under the curve was found to be significant. The IV group outperformed the traditional morphology and morphokinetic algorithms with an AUC of less than 0.75. It was completely automated, eliminating inter and intra-observer variability. However, the limitation of the study was it was retrospective, lack of generalizability, and it used only day 5 embryos. Now, coming to few more studies, embryo grading using static imaging was studied by was well described in this paper by Khosravi et al. In 2019. It showed that the system definitely outperformed the embryologist at the level of embryo selection. There was a significant comparison between the AI group versus the embryologist group. In terms of time-lapse imaging also, there is a paper by Krag et al. Which showed that the AI software outperformed the embryologist. In terms of live birth as well, in comparison to the Gardner scale, AI was better in according to the study by Inatsu and Miyazaki. Borman et al. Also showed that the AI software outperformed the embryologist. The same in terms of AI in pregnancy prediction by Vermiela et al. Ploidy prediction by Erica as well was better than 2 embryologists. It outperformed the 2 embryologists. Now, having said all this, still, what is the advantage of using AI in IVF? It reduces the inter-observer variability. It gives a personalized treatment plan. There is a higher rate of IVF success. It increases the efficiency. It minimizes the medication errors. This is in overall reproductive technology, how AI is an advantage to use. In embryo selection, it improved the accuracy, increased the success rates in terms of live birth, appearance of fetal heart, or the beta HCG positive. It reduced the human errors. There was better reliability and objectivity. Why this matters? The higher accuracy with AI is important to improve the embryo quality prediction. Cross-clinic robustness, there is a comparability between various clinics with using AI and without using AI. There are non-invasive alternatives to PGT in embryo biopsy, wherein an AI can predict the ploidy status of the embryo. Clinical and ethical preparedness, it is more transparent, explainable models are needed before the real world use. So are we there yet? Now, in the debate as well, multiple points pointed towards both positives and in the negatives. I could not find 100% positives about AI, nor could I say that AI is not useful. So where are we at this level? So it requires a lot of fine tuning in terms of embryo selection for the using AI on a full scale basis at present. So what are the challenges and limitations for this fine tuning to not happen? The data quality and the availability, the lack of understanding of the context of using an AI. There are a lot of ethical concerns of unequal treatment programs. Dependence on technology, is it always possible to use a technology at 100%? Integrating challenges between a normal healthcare system and an AI. The cost of implementing an AI technology can be expensive in the initial years. and regulatory hurdles, of course. Now, in terms of reporting, always we have to remember that there should be a proper scrutiny at the level of reporting of these guidelines, and proper guidelines should be formed. The tripod AI is one such guideline which ensures that we have some reportability to the use of AI in embryo selection as well. Now, the importance of having explainability. Now, a popular question that we always are asked and always have a question mark when we go back to bed: are we going to be replaced? Are we going to are is our jobs going to be taken away by robots? Is my job valid for tomorrow? Are we doing the right thing? Now, a lot of questions like this keep on cropping in our minds, but the most important thing which we still hold is change. Change is something which is happening day by day. We are not replaced. We cannot be replaced by the system at present until and unless we incorporate the system to our benefits. So, a few explainable examples of AI that can be used, as in central neural net, convolutional neural networking, was used by Inatsu et al. It provided heat maps indicating areas of focus in blastocyst imaging, aiding embryologists in understanding the AI-driven predictions. So it was a combination of both the embryologist and the AI at play to make a better embryo to be used for IVF. So there is still a regulatory board development in the evolving phase. The US and UK have started implementing guidelines for the use of AI in medical devices as well. So where does the future take us? So time-lapse imaging is going to be big in maybe a few years. There is multimodal integration of multiple systems, providing more explainability using the AI softwares, wherein we have a proper explanation to why we did what. It can be a self or unsupervised learning using an AI. Synthetic and federated learning can be done. We can improve our knowledge about embryology much better using the AI technology, and there can be a better operational efficiency. So, in summary, while AI holds promise for enhancing decision making in ART, challenges related to reporting standards, ethical consideration, explainability, and regulation must be addressed to ensure its safe and effective success. So, intelligence is the ability to adapt to change. Let us start incorporating the change. AI is just a tool to serve medical practitioners, which will enhance their diagnostic abilities. AI will not and cannot replace reproductive medicine practitioners or embryologists, but rather streamline our efforts with the goal for better helping the patients. Thank you.
Thank you, Dr. Aishwarya. I think Dr. Pooja, we'll have Shreya do the debate against the topic, and then we can have the rebuttal.
Right. Okay.
Shreya, if you could share your screen, please. Can you do a slideshow? Ani, can you go back to the first slide, please? So I would like to introduce the second speaker, Shreya. She's a senior embryologist at Ridge IVF Fortis. She's pursuing her PhD on polymorphism in infertile females in North Indian population. She has more than 6 years of experience in infertility and human erection, and she's been awarded the Young Achiever Award 2025 in DNA Labs. She has various poster and oral presentations in Fusion 2024 and Fertivision 2022, 23, and 24. She's MSc Zoology and Diploma in Clinical Embryology from IFS, and she's presently doing her PhD in biotechnology. So Shreya will be speaking against the topic. Welcome, Shreya.
Thank you. Good evening, everyone. Myself Shreya, and I'll be speaking against the motion, that is the disadvantages for AI in embryo selection. So the history and the foundation and the benefits are already been discussed. I'll just brush up. The foundation phase was in 1990s, followed by data collection, machine learning, which began in 2000s, and followed by time lapse, and now the present scenario where everything is used right now: the deep learning, data collection, machine learnings, and the time lapse as well. The benefits have also already been discussed. With the help of the softwares EDA Score and Live Whisper, we are able to do the embryo selections, sperm oocyte quality assessment, personalized treatment plans such as best stimulation protocol, optimizing timing for egg retrieval, individualized medication dosages, and even in the PGT, it is used right now for the prediction of mosaicism level, flag likely positive, and prioritize eukaryote embryos. It is also used for the automation such as lab processes, reducing manual errors and standardizing lab protocols. But the main problem lies in the algorithms which are being used today for the AI. That is the limitations and challenges. One of the biggest limitation is the data quality. AI is only as good as the data it is trained on. Biases or errors in the datasets can mislead, ethical and legal issues. Ownership of data, transparency of algorithms, and consent are ongoing concerns. Lack of standardization. There is no universal criteria for AI tool validation across fertility centers, and cost, which is already one of a big problem of IVF. It just burdens the patient more. Lack of explainability, that is the black box problem, which we will discuss in more detail in the further slides. Risk of over reliance. Embryologists or doctors may begin to trust AI more than their own experience. This can result in ignoring context-specific factors like prior IVF cycles, uterine conditions, personal values, etc. And one of the biggest problem is biased or incomplete training data. If AI is trained mostly on data from a certain population, clinic, or equipment type, it may not generalize well of two different ethnicities, age groups, or lab protocols. Most of the AI tools used today are not yet FDA approved or fully validated in large scale clinical trials. And one of the biggest concern is who owns the data, how are decisions being made, and could AI devalue viable embryos based on subtle differences? So, all these problems can lead to two types of errors, type 1 and the type 2 errors. In embryology, we can say a type 1 error is false positive, that is, when an embryo is incorrectly classified as viable when it is not, and type 2 error, that is false negative, which can happen when embryo is incorrectly classified as non-viable when it actually has the potential to develop into a healthy pregnancy. This all depends on the performance KPIs like accuracy and precision that has been fed to the data. It may work up in a business setup, but it is not yet that much precise. That is more than 95%, which should be in case of a medical use. The algorithms used right now in these softwares are, one is CNN, the type of deep learning algorithm that excels at image analysis, recurrent neural networks, a deep learning algorithm that are particularly well suited for analyzing sequential data such as time lapse videos of development embryos. The support vector machines, SVMs, or a type of machine learning algorithms that can be used to classify embryos based on set of features, or the random forest that combines multiple decision trees to improve the prediction accuracy. But all of these have a problem. That is, the CNN requires large data sets and graphic processing unit training. The random forest may be prone to overfitting if not properly trained. The SVM requires careful selection to input features. The linear regressions limit accuracy for highly complex data. The ANNs high computational power, difficult result interpretation. The gradient boosting needs proper parameters tuning for optimal performances, and the LSTM highly computational cost and sensitivity to data number. This is one of a recent study of 2025, which states that by using embryo selection for AI, we can have potential risk of embryo commodification, risk of discrimination, algorithm bias, black box models, unclear communication, trust issues, financial issues, safety concerns, as well as liability issues. Another paper of 2019 states that currently AI researches mainly focuses on image analysis of sperm cells and embryos and an outcome prediction of ART. The application of early disease prediction and diagnosis treatment and prognosis evaluations are rarely inadequate. The comprehensive review noted that AI models for reproductive medicines are often trained on small, single center retrospective data sets, which compromises their performance, applicability, and generalizability. So this is how an AI works. First, the data is collected, feature extraction is done, model training, and then the decision support. Any problem in any of the following steps may lead to either to a type 1 error or a type 2 error. This is another paper review works on AI assisted embryo selection with special focus on explainable artificial intelligence. So, artificial intelligence and explainable AI basic works on two systems, post hoc techniques or the intrinsic one. The post hoc techniques such as SHAP and LIME, they interpret trained data models. They obtain the explanations by perturbing the inputs and observing the changes caused by the outputs. Whereas the intrinsic model designs are explainable by construction, but both of them have some problem, such as biological relevance. Explainability outputs may not align with embryo biology. Single method dependency. Most studies rely on one of the explainable AI methods, limiting robustness. Responsibility gaps. Opaque models obscure decision chains, making it hard to assign accountability in clinical context. Trust versus automation bias. Clinicians may disrupt AI or even rely on its explanations aren't meaningful. Patient communication. Explanations must be understandable to lay people and used in clinical guided consultations. One of the biggest concern is the geographical distribution of the data that is being fed to the AI systems. The geographical distribution of studies of AI applications in infertility. This is a paper of 2025 which states that the most of the patients that are being used to study the male infertility in AI have been from a Caucasian countries, especially in USA, which leads at 29%, followed by China and then Israel, reflecting significant research activity in these groups. This visualization highlights the concentration of AI research in male infertility across different countries, emphasizing area of focus and potential gap in global representations. Many AI models are trained on homogeneous database with little representation of non-European ethnic groups. As a result, models often perform better on overrepresented groups and less accurately on the other ones. This is another study which was conducted across 14 IVF clinics in Australia and in Europe. It had around 1,066 women under 42 with at least two blastocysts. It was divided into two groups, the AI, which was used to using IDA score, and the other is the control group. And in this, we can see that there was not much difference between both the groups. Additionally, the study noted that the standard embryo selection performed better than expected with a 48.2 pregnancy rate versus the anticipated 35.4. Now, the biggest issue is the black box. So, black box is in AI is referred to a special deep learning models whose internal workings are not easily interpretable or understandable by humans. AI decisions are often non explainable. Why was this embryo selected? We do not have any clear answers. And one of the biggest risks is clinicians and patients make life altering decisions without understanding the reasoning. This is a paper which tells us about the problems of the black box. The black box model creates information asymmetries. The use of black box models creates an information asymmetry between the company selling the tool and the clinicians having to make daily decisions as to which embryo to be transferred. And another one is the bias level. The machine learning embryo selected is an ongoing process whereby the machine learns and adapts its algorithms from the previous generation of data. If any biasness is occurred at any point, they will not only would be the bias be perpetuated, but it will also be magnified in the future generations as the machine will learn from the biased data. These are some four new studies which have compared the AI tools and the control group, that is the embryologist doing the selection, and in all of them there was no significant result that was observed. So the future directions for can be development of more sophisticated AI algorithms, personalized embryo selection, integration of AI with other technologies such as CRISPR gene editing to improve the success rate of IVF, development of explainable AI, and establishment of ethical guidelines and the regulatory frameworks. That's it. Thank you.
Thank you so much, Shreya, for the debate. And I will request Dr. Pooja to please take over for the questions and the rebuttal.
Thank you, Dr. Ankita. So, Dr. Aishwarya, and both have presented very well actually, and kind of confused me as well, which is the best. But what I feel, I have like few questions with the Aishwarya.
Yes,
Aishwarya,
ma'am.
what you feel since you are for the AI? what are these AI tools currently present in the Indian scenario, which we can use uh, in the presently where there is no time lapse? So how we can integrate those things, and how what are the challenges you feel we can step down?
Ma'am, the first and foremost challenge would be the equipment optimization and the use of the software and basically the cost. The IVF laboratories that we are working at present do not have the facility to integrate an AI system. But having said that, at the level of RFID, at the level of labeling the embryos, I think AI would be much better than simple manual labeling as such, ma'am.
No, it's not. Question is not about the labeling.
Okay.
Question is about, since suppose we are running an IVF center and we have around 500 patient data, right? And we
Yes.
want to incorporate, we want to retrospectively check, or in future coming patient, for the coming patient, we want to upload the images and
Mm.
want to do the best embryo selection for the transfer. So is there any software which we can use currently in our setups where there is no time lapse?
At present, I don't know any such software which is used, ma'am. I'm not sure about this. I'm sorry.
Any software which uses images? Have you
I'm
heard about
sorry.
live whisperer?
Yes, ma'am. I've
So
heard
how
about.
how it how it work?
The images at different levels of the growth of the embryo are stored, and then retrospectively we do analyze, just like in time lapse imaging. But these are static images, not dynamic images.
So is there any criteria for taking these static images? Or we can randomly click and upload on the software, and then on the basis of AI?
It is time-based, like I'd say PN stage, 17 hours, 34 hours. Specific time criteria is given accordingly at that time frame itself. The images are taken of the all the embryos at one point.
So which mean every day we have to take out the dish, we have to click the pictures, and then we have to upload. Okay,
Sure.
that means it is giving more exposure or kind of discontinuous culturing.
Culture system.
Okay, got it. So, Ruchira, I have questions for you. Why you are against of it? Because everybody is incorporating AI in different aspect of IVF lab. Like you have justified every aspect, I feel. But in case we want to welcome this new technology, so how we can welcome?
Uh, Hi, but actually, we've used Live Whisper. We try to incorporate it into our daily life for helping us better embryo selection. But the biggest issue that we faced with Live Whisper was that if we clicked a photo on day 4 and then on day 5, like sometimes we just need a day 3 transfer or a day 5 transfer, it will show that non-viable on one day, and on day 5 it will show that it is viable, it has a better genetic health. We even had some cases where in Live Whisper, when the PGT was done, the result was aneuploid, but it showed us that it was viable. So right now we are not incorporating it in our daily systems. We try to, but the only, I think, time lapse, yeah, maybe time lapse is a one of the better options to use embryoscope, so that we are not giving them exposure daily, taking them out, checking it daily every day. Other than that, like now I cannot say that I'll support Live Whisper or EDA score.
Yeah, see, basically, we cannot deny the importance of AI in the complete medical profession, because you also know that with the AI, we can have, if the AI is, if we are trained enough, right, to use how to use the AI properly, then definitely it will improve the accuracy, standardized practice, right? Because
Yes.
AI is data driven, right? And
Yes.
it may increase the success rate also, but I agree with the point that it is a database program, so sometimes it deselect the very good or viable embryo.
Yes.
Like, do you feel that we need more training to use
Yes.
AI? And
That's the biggest issue. If we have more large data set, especially something for the Indian ethnicity, right now they are not much regarding our ethnicity. It's majorly Caucasians. So if
Asian
we
data,
have,
we want large Asian data.
yeah,
Okay, and
large database, and like the algorithms also need to be improved. The black box imaging that I showed, like we need to know that why it is selecting this embryo, so that we can explain it to the patient also. It is just giving an answer yes or no, but there are no explanations that why, how much percentage it would be bad, or exact mosaicism, or everything is not known.
okay, so people who are having the time lapse, I think they can go for these AI-based software for the selection of embryos because
Yes,
they have the complete database and they have the complete history of the patient and also the journey of the oocyte from where it is started at what morphological selection, how was the morphology at the time of oocyte and when it become the day 5 embryo. So they have the complete history. So they are the best person
they are
to
the way.
use these AI tools for the embryo selection, isn't?
Yeah, they are.
Oh. So I would like to invite any of the volunteer. We have around 24. Any questions regarding uh, favor or uh, how to use the AI things in the laboratory are most welcome.
If the audience has any question, you can ask, please.
So I can see Aarti. Aarti, hi, Dr. Geeta Khanna. Hello, good evening, ma'am. So if there is no questions, Dr. Ankita, can we summarize the this topic?
Yeah, I think you can just summarize with few points for like a take-home message kind of a thing, and then we can wrap up. Thank you.
Yeah. Okay. So basically, since we have seen both sides of stories, and we all agree that this AI things always like since we started using AI, it is improving the accuracy, standardizes our practice, because it is a data-driven things and it gives the insight from the data, and also it increases the success rate in many aspects of medical sciences. But in terms of when we talk about the as a tool for the embryo selection, there's a lot of challenges. Like training is one challenge. Asian studies and large data is still missing to actually adapt this. And sometimes there's a lack of regulatory framework in India, and there's a lot of lack about the awareness and the adaptation also. Not many people are still in the phase that they can adapt and welcome this new technique. Cost is a very important thing in Indian scenario, and also the accessibility of it. So I feel it will take a little bit more time to adapt and accept as Indian as a AI tool, but slowly and gradually AI will be become one of our friend, I guess, and we should not be afraid of this new technology. We should welcome, but with the sincere approach and with the large data.
Okay, thank you, Dr. Pooja. Thank you, Aishwarya. Thank you, Shreya.
Thank you,
Thank
ma'am.
you, thank you, Dr.
Good
Ankita.
night.
Bye. Good night, everyone.
Good night.